Bell's palsy, facial paralysis. Descriptions: disruption of the seventh cranial nerve. The facial nerve results in paralysis of the ipsilateral facial muscle, including the orbicularis oculi, responsible for eyelid tone and closure. The facial nerve can be injured by many mechanisms at multiple sites on its long tortuous course from the brainstem. These are traditionally divided into supranuclear, nuclear, and infranuclear lesions. Bell's palsy is the common type of facial neuropathy and refers to idiopathic facial nerve palsy with typical clinical features. The term is also frequently used to refer to all facial nerve palsies. In addition to Bell's palsy, stroke, infections, trauma, and tumors can damage the nerve. The most common trauma to involve the facial nerve is an acoustic neuroma, either directly or as a result of surgical trauma during its resection. In this case, damage to the fifth cranial nerve, the trigeminal nerve, is also possible, leading to corneal anesthesia and possible neurotrophic keratitis. Symptoms: Bell's palsy usually has a rapid onset and is more common in people with diabetes mellitus and hypertension. It may be associated with decreased hearing and diminished taste. Approximately 75% experience a complete recovery. Recovery usually commences within several weeks and is complete in 2 to 3 months. In the remaining 25% of patients, a variable degree of weaknesses persists. If exposure of the ocular surface occurs, redness, pain, photophobia, blurring of vision, and epiphora are common. Sign: there is facial drooping on the affected side, including the mouth. Often the eyes on the affected side cannot be closed, and it may be difficult to move the forehead. There may be associated paralytic atropine. With exposure, conjunctival infections, edema, and epithelial disruptions are common. Corneal epithelial disturbances are also common, ranging from mild punctate erosions to frank ulceration. Corneal ulcers resulting from exposure are usually inferior, rounded, and have a regular edge. Significant: there is usually a marked cosmetic concern and, if exposure keratopathy occurs, moderate discomfort and threat to sight. The management: tear supplements. Tear supplements are of prime importance in protecting the ocular surface from desiccation. During the acute phase of the disease, this is achieved with the frequent use of usually unpreserved lubricant drops and ointment. Consider also the use of a therapeutic contact lens. During the day, ocular protection can be aided with the use of sunglasses, and at night with tapering of the eyelid. Dosing: lubricant ointments (BD) and topical drops and/or gel QID continued until good lid function returns.